Hi, everyone. Welcome back. Today, we're joined again by Dr. Stenehjem to give our weekly COVID-19 update from the state of Utah. Dr. Stenehjem, as always, thanks for joining us. We appreciate the time.
Thanks for having me.
So let's start with case trends. I want to go over everything that's happened in the last week, specifically yesterday. The total case counts in the state of Utah was 121,485. Yesterday's case counts were 2,110, which is a 19.1% positive rate for the last 7 days, and an average case count of 1,803 for the last 7 days. We had 6 deaths yesterday, bringing our state total to 625. And we had 382 hospitalizations as of yesterday, with our state total of 5,755. Eddie, let's break those down. How are we doing? How are hospital systems doing? How is your team doing?
Yeah. First of all, I got a new chair. Looks like I'm in a spaceship. So hope that doesn't distract anybody from our broadcast. We're the same as we were last week. Our counts continue to go up. Over 2,000 cases yesterday. That was the second highest day we've ever had in Utah. A couple notable features from yesterday is that our daily test positivity rate was 32%. So 32% of all the tests done were positive. And we also saw that the test numbers done yesterday was down to about 6,000. And so we've been running around 10,000, 12,000 tests per day. And now we dipped down to about 6,000 to 7,000 yesterday. And has a much higher test percent positivity because your denominator is that much smaller. So that's an alarming trend for us to see that daily test positivity rate go up 32%, a decrease in tests, and yet we still had 2,100 cases. And so it just speaks to the fact that we have continued aggressive rise in our cases, and maybe a trend to not testing nearly enough. I mean, when you have a test positivity rate that high, that just means you're not testing enough. We are missing thousands of community cases a day, likely based on that test positivity rate.
Sorry, real quick. That I did not realize yesterday's rate was that high. That's crazy. That explains why the 7-day rate jumped like a whole percentage. So that's crazy. So continue, but just had to add that there.
No, and it's been going up in the past couple of days, and so it really is. It's not a marker we'll hold our hat to, but it definitely is an indicator of test-seeking behavior. So it could go up because fewer people are coming to get tested, and the only people that are getting tested are the ones that are really sick. That can be an indicator of that. It can also be an indicator of just aggressive community-based transmission. And you're just missing tons of people. And so I think it's actually, in this case, probably both. The fact that we're having fewer people tested and we have very high significant community transmission. If you look at the demographics of this, what you're seeing is that 15 to 24-year-old age group went up, and now it's just pegged at a very high level. And so we're getting lots of that 15 to 24-year-old group that's positive. That hasn't come down yet, and we're seeing this continued rise in all the other age groups as well. Maybe some plateauing, but too early to tell. And that 15 to 24-year-old age group is fortunate in the fact that they don't get that sick. I would say the majority don't get that sick. I would also keep in mind that we had a death at one of our hospitals of a 21-year-old, and we also have a very sick person in our hospital right now that's in that age group as well. And so it's not that these kids don't ever get sick, it's just that they're not as likely to compared to older age groups. And so really high rates in those people, and the challenge with that, and what we know, is that they then go home and spread it to their parents, their grandparents, or their friends' parents. They are a huge source of transmission for us. And that's a challenging group to really have them minimize their social interactions, as we learned on Halloween, for example. How's the hospitals doing? If you look at our Intermountain hospital census each day, that are from COVID patients, the line is linear. It's just going straight up. And so we have more and more patients every day in our hospitals with COVID-19. And that trend will continue. We know, hospitalizations are delayed 7, 10, 14 days after we report the cases. And so even if we stop transmission today, our hospitalization numbers would continue to go up for the next 2 weeks. And we clearly are not stopping transmission today. And so those numbers continue to rise at a rate that's pretty scary for us in healthcare. Intermountain Medical Center, our respiratory ICU is full. Our shock trauma ICU is full. We've now expanded into our cardiac ICU and our post-cardiac ICU, and we've got a number of patients on ECMO. So these patients are now going into ICUs that are traditionally used to care for, post-cardiac surgery patients, or ICUs where are being cared for those with acute MIs and taking up bed space in those facilities or in those ICUs. All Riverton pediatric patients are now being admitted to Primary Children's Hospital. And so all of those pediatric beds at Riverton hospitals are now designated for COVID beds. So yeah, we're not doing great. Our nurses, our doctors, everybody is tired, they're exhausted, they're mentally and physically spent, and there's no end in sight.
Someone just asked us a question really quick about the case counts, and they wanted to know, if you're wearing a mask and social distancing, why do our case counts keep going up? And I think people should understand, if you look about some of the things that were reported over Halloween, that's not really happening. But do you want to give your medical opinion about why you think the case counts are still going up?
It's a great question, and for a couple of reasons. There's a lot of the Utah population that is doing this well. And I don't want to ignore the fact that, our mask compliance based on some okay numbers from the Department of Health is 70% or so. Okay, so that means there's a lot of people that are doing this well. There's a lot of people that are practicing socially distancing. We thank them for that. But there are large populations that are not. I think the big party at Halloween is a great example. Right? So thousands of people came together, dancing, close contact. There's going to be spread from that environment. That's going to lead to more cases in older people. The other really big point that really needs to be emphasized is that where the Utah Department of Health has seen a lot of these cases are in families and social circles. And so we see lots of spread within families, and then also spread with events that are occurring in people's homes, many times with less than 10 people, but you're not wearing a mask and you're in close contact with other people, and that's when we see spread. And so, we really let our guard down when we're in our houses. These are our safe spaces. But if you go out and have somebody who gets infected and then they come into your home, even if you're only there with 10 other people, that's in a great way to spread the virus. And so that's a couple of the major hotspots that we're seeing, is that in-home spread amongst families and within social circles, where we do let our guard down and our masks come off, which has huge implications for, this big holiday we've got coming up in a couple of weeks.
2 points to that. I want to talk about Halloween. You brought up the parties that we saw, and that it's spreading within groups of people. So Halloween was about less than a week ago. When can we expect those, if there was spread, when can we expect to see the case counts kind of indicate that actually happened?
Yeah, what we've learned from Memorial Day, Labor Day, Mother's Day, these previous holidays that we've had, is that typically you're going to see case counts go up 7 to 10 days later. It's going to be really hard for us to make a differentiation because our case counts continue to rise. Right. So, if the trend continues to go up, it's going to be hard for us to say that was due to Halloween. If we see kind of a change in the slope, if we see a change where that case count continues to go up but higher, we may be able to relate that to Halloween. But given our current trend with an increase in case count, it's going to be pretty hard for us to draw any parallels to the holiday, compared to Memorial Day, where we had essentially a flat case count. Like it was pretty flat. And then we saw this uptick after the holiday that we could easily blame on it. It's going to be a little bit more challenging with Halloween right now.
I've also seen a lot of people talk about not getting tested. They say, we're young, we don't need to get tested, we're not going to get a treatment, we're not going to end up in the hospital. But why is it so important that if you do have symptoms or you were exposed, that you get tested?
Yeah, so it's so important if you have symptoms to get tested, because that determines then your quarantine period, which is not something, a young person wants to hear, right? But if you are positive, you have now a 10-day period where you can transmit this virus, and you can transmit this virus to your parents, to your grandparents, to community members, and they're the ones that get sick and end up in the hospital and potentially die. And so finding out your status is so important to really prevent that ongoing transmission. And so if you have symptoms, especially, young people have mild symptoms, you need to get tested, so then you can really take the appropriate public health precautions to prevent the spread to other people. And that's the way we stop this virus. Testing is a component of public health. It's not the be all end all. It has to be paired with good quarantine procedures from a public health standpoint to prevent that spread. And I think we should make a point, the fact that, if you're exposed, if you've had a close contact, yes, you can get tested, right? That's a good way to know, like, do I have it right now? Yes or no. But if you get tested after an exposure, you still have to self-isolate yourself. You still have to quarantine yourself for 14 days, because all that test tells you is that you're negative on that day. It doesn't tell you that you're not going to turn positive the next day. And so, having a test after exposure is good. It gives you information, but it doesn't change your quarantine period. Okay. So if you get exposed and you get tested 3 days later, well, you very well could turn positive day 4, 5, or 6, or even day 10 or 11. So, a test is good after exposure in terms of contact tracing and things, but it does not change your quarantine period at all.
What if you want to get tested and don't qualify? Is there other ways to get tested? What are your suggestions for those people who would like to get a test just to be safe, but actually don't qualify for like an Intermountain test? Are there other resources they can go to?
So there's plenty of people that offer tests across the state of Utah. So Intermountain, the University of Utah, the State Health Department, Test Utah, they offer the majority of tests, but there's certainly other places that you can get a test. There's freestanding urgent cares, there's some primary care clinics. All of these places have different platforms. It may be a different test. It may be a turnaround time that is longer than you'd want. You just have to be really kind of knowledgeable of what kind of test you're getting. The rapid antigen tests, they miss a lot of patients, right? They don't have the sensitivity as a standard PCR test. And so they're going to miss some patients. And if you get a negative test on an antigen test, that may be a false negative. And so you really just have to be careful in terms of how you utilize the test. Somebody who wants to get tested that's asymptomatic because they want to go to an event 2 to 3 days later, well, all that test told you is that you were negative on that day. It doesn't say anything about, what your status is 3 days from now. And so it's, I would say, really think twice about the utility of a test if you just want to know, and really, focus on getting tested if you have symptoms or you've been exposed, and at the direction of the Utah Department of Health.
Let's talk about Thanksgiving. It's in about 3-ish weeks, or 3 or 4 weeks. And I want to just talk about your suggestions for what people can do. Would you prefer someone gathers inside or outside? And then whatever that distinction is, should it be family and friends, people you live in the household? Let's start there.
Yeah. We anticipate that we're going to have really high rates of COVID-19 in 3 weeks. And I say that because we don't see any major public health change occurring in the next few weeks, just based on, conversations that are happening at the federal or at the state level. And so we have to realize that our transmission rate of COVID-19 in the state of Utah is off the charts. It's in the top 10 in terms of states. It is really, really high. And so we know that if you get together in a group of people that's large, the chance of transmission of COVID-19 is very, very high. Okay. And so we really need to think about that as we go into Thanksgiving, just because our health system can't tolerate any more than it currently is, receiving right now. And so to answer your first question, outside is always better than inside when it comes to this. The challenges are going to be is that sometimes at Thanksgiving, outside isn't really pleasant. I mean, take a look at last year, we had a major snowstorm on Thanksgiving weekend. That's not a time to be, celebrating outside on the deck. And so we're really going to be limited by weather Thanksgiving, and we can hope for nice weather. We can go outside, that'd be great, but we can't count on it. And so what do? The safest way is to have a very small family-centered Thanksgiving, immediate family, only the people that you live in the home with. That is the best and safest answer, period. And we know that if you have large family gatherings, we will see transmission of COVID-19. It sucks because this is a time to get together with family and give thanks. And that's what we all love to do at Thanksgiving and Christmas. And right now, that is not something that we can do safely. And we really need to think twice about, those family gatherings. And so I would recommend to say the safest thing you can do is to have a family Thanksgiving at your home and not invite, your extended family over, unfortunately. If you can be outside, great, be outside. If you are going to have people over, if you're not going to heed that advice, then there are some things you really have to consider. So one is masking inside. I know it's weird, but that's just kind of the new normal. If everybody wore a mask inside, then you could decrease transmission. You obviously can't wear a mask when you're eating, but you could have separate tables for different families. And separate the families within the house at each individual tables, make the table 6 feet apart, and do that way. And then when you're not eating and drinking, you put the mask back on. And then, another thing to think about is the time before Thanksgiving, and really think about the 2 weeks before Thanksgiving. If you're going to have a small gathering, which is not what we advise, but if you are, you really need to focus on the time, the 2 weeks before Thanksgiving, because that's the time where you potentially could get infected, may or may not have symptoms, and then bring that infection into that Thanksgiving crowd. And if you're going to do it, you need to tell the participants that are coming to your Thanksgiving gathering is to say, those 2 weeks, you need to essentially quarantine. Okay. You need to stay at home. If you go out, you have to wear a mask. And there's no other socialization in those 2 weeks leading up to Thanksgiving to really reduce the chance that you're bringing COVID-19 into that gathering. But that takes a
question about that really quick. So say you have this group of people, it's your parents and maybe just your siblings, you don't live together. During that 2-week quarantine bubble, can you still see them, or does that slightly defeat the purpose?
I would say just limit it to your family. If you could, people always talk about these like COVID families, right? My COVID bubble. That only works if those people that are in that bubble, that's the only bubble that they have. But if the person that you're kind of intermingling with during COVID also has other people that they're mingling with, and they have different COVID families, well, that COVID bubble just got a lot bigger. And so it all depends on the communication between the families and how serious they are about this, because it only takes one family or one person not being serious about wearing a mask, not being serious about socially isolating, and then you got everybody infected. And so
what about
it's a really slippery slope.
And what about the grocery store during those 2 weeks? I think obviously you can't shop for Thanksgiving 2 weeks in advance. Right. So do you send one person out, two people out? What's your suggestions for that?
I think what we've seen is that with masking and with good, proper hand hygiene, you can do these things safely. We aren't having hordes of people getting sick by going to the grocery store. We're not having hordes of people getting sick by going into businesses, Ace Hardware, Home Depot, those types of things, because those are controlled environments. You're wearing a mask, you're staying, good bit of big, 6 feet apart. So you can still do that. You can still go as long as you're safe and you abide by those social distancing measures, and you're not in there socializing with your mask off. I mean, who does that these days in grocery stores? But those things we can do, and our businesses have been great, right? In terms of requiring masks and keeping their employees safe. That's the whole point from a business standpoint. You have to keep your employees and your shoppers safe. And so to answer your question is, yeah, you can do that. You can go to the grocery store, you can do the click list, you can, do the pickup. There's so many options you can do to make those things safe that I think you can still do it and still prepare. But again, it really is trying to limit that group for Thanksgiving, ideally to your immediate family only.
We've gotten this question a lot. If I can gather for the holidays, why aren't schools shutting down permanently? I think I asked that incorrectly. If we can't gather in big groups for the holidays, why aren't schools shutting down? Sorry, I asked that in reverse.
Right. Well, it's really interesting to look at schools. And based on the data that we have, we do not think that we are seeing transmission of SARS-CoV-2 in the school setting itself. So in the classroom setting where people are in the classroom, where they're masked, where the teacher's masked, maybe there's plexiglass, that's not where we're seeing transmission of SARS-CoV-2. Where we're seeing transmission of COVID is after school. It's when people go to their extracurricular activities, the masks come off, they go into their friends' cars and the masks come off and they socialize, and it's after school. School is a relatively controlled environment with that requires masks. And I think we've, didn't give our kids enough credit in terms of their compliance with masks. They're doing really well with it. And so I think it's more of a good question to say, okay, why are we still having extracurricular activities? Why are we still having these sporting events? This is where we're seeing transmission, not necessarily in the school. And, you can't make that parallel between school and a social event for Thanksgiving, unless you say your social event at Thanksgiving, you're going to space everybody 6 feet apart and everybody's going to wear a mask. If that's the case, well, then that's going to be a pretty safe event. But it really is the transmission that's occurring post-school, after school, in those non-controlled settings. I think our schools are doing a great job, but it's really more predicated on the fact that they're getting infected outside of school.
I know I see the like soccer teams and everything playing a lot around my house. So that'll be interesting, especially leading up to the holidays. I want to switch topics to the vaccine. Is there any sort of update that you can give us on the vaccine or any other studies or therapeutics that we're currently seeing for COVID-19?
Yeah, so let's talk about the vaccines first, and we can talk about other therapeutics after that. So 4 big trials that are currently in phase 3 studies, Pfizer, Moderna, those are the 2 that are farthest along. And there's AstraZeneca and Johnson & Johnson, or Janssen. And so Moderna, Pfizer, those are going to most likely be the 2 that we're going to receive results the quickest from. And we suspect that we may hear about top line results, not in a scientific paper, but just from the company by the end of November. That's kind of mid to end of November. That's kind of the timeline we're looking at. And then that would go to the FDA for an approval for an emergency use authorization. And then you'd have distribution after that. This is assuming that the vaccine is shown to be effective. That's a big assumption to make. The 2 vaccines that are coming out are RNA vaccines. These are not vaccines that have ever been used in a clinical context. There's no FDA approved RNA vaccines on the market. And so we hope that they're going to be effective. They looked good in phase 1 and phase 2 trials. And we just don't have any results from phase 3 because I don't think that they've looked at any top line results yet. Johnson & Johnson enrolled more sites just recently. They'll have, some more time to enroll. They're trying to get 60,000 people in their study. So it's a huge study, and they're using an adenovirus vector. And same thing with the AstraZeneca and Oxford vaccine. Those two would probably be second in the kind of the second phase of potential approvals. And so let's just assume that the Pfizer or Moderna vaccine gets approved, that they have positive results, whatever they may be. We could potentially see distribution, as long as the FDA process goes quickly, potentially distribution early December. But keep in mind that that distribution is going to be at a state to state level, and it's going to be a very small amount of vaccine initially. They're not going to have the millions upon millions of doses that we're going to need. And so that first phase of vaccines are likely going to go to critical healthcare workers. And then phases after that will start including more and more people at high risk, but it's really going to be dependent on what the studies show in terms of the effectiveness. That's going to dictate what populations are actually going to get vaccines. Does that make sense, Amanda, in terms of timeline?
Yes, and you answered someone's question I asked about who is going to be recommended to take the vaccine. They specifically asked about COVID positive people and whether they'd be considered in that initial distribution. It sounds like it would depend on their risk level, essentially.
Yeah,
is that correct?
That's a very good nuanced question. The studies that are ongoing in these phase 3 trials are looking at all comers. And so if you've had COVID in the past, they're going to take you and put you in the vaccine trial. And they look at your baseline serology, and most likely there's going to be sub-analysis, not most likely, there absolutely will be sub-analysis to say what population of the people that we vaccinated was this protective in. And unfortunately, it depends on how you look at it. It's really going to be dependent on how many cases they have in their trial to be able to determine how granular they can get in their sub-analyses. And so most likely we won't know that particular data early on. And so that most likely won't go into any of the decision-making in terms of who gets vaccinated or not. It most likely will then just be based on, probably age and comorbidities is what I'd imagine. But again, what we'll eventually see in our trials is to say, in what groups are these vaccines effective? There's a chance that these vaccines are not going to be effective in the elderly. All right. So flu vaccine, for example, is a great example. Like, it's just not as effective in the elderly. We give them a double dose to try to overcome it. And so if the vaccine isn't effective in the older population, we probably aren't going to give it to them. And we're going to focus on vaccinating, people that it isn't effective in. And so it's really going to be dependent on the nuances of the study and where this vaccine is effective, and what decisions and what we can glean from those early studies is really going to be dependent on how many events that are in those studies and how effective the vaccine is. And so we will be looking at that aggressively within Intermountain to try to make those determinations of, do we think this is a safe, effective vaccine that we want to put out in the community? And if so, to who? And so unfortunately, we don't have answers to those questions until we see the study results.
You brought up a really good point about if the vaccine doesn't work in the higher risk population, we'll start going towards another. And that thought came into my mind about, well, shouldn't we do the younger population who's spreading it to the older population in order to kind of stop that spread? And I don't know if that's been thought about. I'm sure it has, but that'll be interesting if that part happens. Did you have any thoughts about that?
Yeah, it's definitely something that's being thought about, and there's plenty of people doing mathematical modeling to say who are the people we should vaccinate to stop the spread. I think the other thing that we should really think about is that, this vaccine is not going to be a magic bullet. Okay, as much as we want this vaccine to be just this like magic bullet that's going to just get us out of COVID, it's probably not going to be that. And so, there's some vaccines. Think about measles vaccine. Think about hepatitis B vaccine, hepatitis A vaccine. These are vaccines that if you give them, they're almost 95% efficacious, meaning that you will not get measles, you will not get hep A, you won't get hep B if you get vaccinated, right? Contrast that to the influenza vaccine that has an efficacy rate of 40 to 50%, but it reduces the severity of illness if you do get influenza, okay? And so this vaccine, if we had to imagine just based on the data we've seen so far, is going to look more like a flu vaccine than it's going to look like a hep A or measles vaccine. Okay? And so one is that we don't anticipate the vaccine to be fully 100% effective. And you have to look at the vaccine hesitancy that is currently in the state of Utah. And so early reports show that 50% of the population would say no to this vaccine. Okay, so we can't, because of that, this is not going to be a magic bullet, right? If 50% of people aren't taking it and it doesn't fully eradicate the infection, yes, it's going to be helpful. And we hope it'll be helpful in the population that has severe outcomes, but it's not going to eradicate this infection. We're still going to have to be dependent on therapeutics and testing and public health measures in addition to vaccination.
Before you get to the therapeutics, someone just asked us a quick question. They said, what if we just want to get the virus and beat it so we can get done with it? What are your thoughts on that?
So I think, do you interpret that as like a herd immunity question? Man?
I think so. That's the only comment they've given us. Yes, I'm assuming they're asking like, yes, a herd immunity. I get it. I can just be done with it, not worry about it, move on with my normal life.
So, and I can't remember if we've covered this before, but so SARS-CoV-2 is a coronavirus, right? So there are 4 seasonal coronaviruses that we contend with year after year. These are the viruses that cause essentially the common cold. We get these viruses repeatedly. We get them time and time again. And typically the immunity that you have to a seasonal coronavirus is measured in months to maybe a year, okay? And so you can repeatedly get infected with coronavirus. We expect that based on the immunological data that we have so far, waning antibody levels, waning T cell responses, that when you get infected with SARS-CoV-2, the new novel coronavirus, is that you're not going to have lifelong immunity. And so what this viewer is saying is, well, let's just all get infected. Never mind the burden that would put on our health system, for example. Okay, we're going to ignore that for just a hot minute here. Well, that's great, but then we're all going to be in that same position in 2 years or a year and a half or a year, we don't know, where we're all going to be susceptible again, right? So, the herd immunity concept doesn't work for a respiratory virus that you don't develop long-standing immunity to. You're going to be able to get this again and again, most likely, based on the current science of immunology. Okay, so that's one of the big things, is that herd immunity is not going to exist. This is going to be part of our respiratory viruses from here on out, most likely. 2 is that if we just say, okay, rip off the Band-Aid, take off the masks, screw the social distancing, we're getting together. I want them to reflect of what's going on in our hospitals right now with 70% mask compliance, with masking in schools, with social distancing, with decreasing crowds, no concerts. These are very significant public health measures. And right now, our hospitals are exploding in terms of their volumes. We have ICUs that are full. We are expanding. We're making new beds. Those are all occurring in the face of, a lot of Utah abiding by good public health measures. And so if we said, nah, screw it, let's just go herd immunity. If you had a heart attack, forget it. You're not getting a bed. If you're in an accident, sorry, we don't have any beds. So, the consequences of that are dire and not something that we want to undertake in Utah.
Hopefully that helped answer that question. I think that was a great way to put it, of the other normal day life accidents and situations that happen. I want to switch to therapeutics and an update on some studies that are happening. I can never pronounce this correctly. Will you say it for me?
Monoclonal antibodies, yeah.
Yes. Will you give us an update on how that's going?
Yeah, so if you look at therapeutics right now, the FDA approved remdesivir. Remdesivir is a direct-acting antiviral. And so that's a drug that we're using in the vast majority of hospitalized patients across the state. We're also using steroids, which has been shown in a number of trials to be effective, especially in those that are on higher levels of oxygen. So remdesivir and steroids continue to be our backbone of therapy. There's a lot of talk about convalescent plasma. That is essentially taking the plasma of somebody who has been infected and has recovered, taking their plasma that includes all of those different antibodies, some to coronavirus and all the other antibodies to everything else that that person has, and then giving that to somebody that's acutely infected, thinking that they're going to get some antibodies to SARS-CoV-2 that's going to potentially help them. What a monoclonal antibody is identifying the specific antibody to SARS-CoV-2 virus and giving that specific antibody in high quantities to an infected patient. Okay, so that's called a monoclonal antibody. And there's multiple different pharmaceutical groups that are now getting into this. The ones that are farthest along is Regeneron, which we heard President Trump got, and Eli Lilly. So those are the two companies that are farthest along, but there's loads of others that are in development. And so those studies have looked at two populations. One is the inpatient, acutely ill, moderately to severely sick population, and the outpatient population. In the hospitalized patient population, there's actually been two studies that have been put on hold because of lack of efficacy signal, meaning they just didn't work in terms of reducing severity of illness. There's one that's still ongoing, looking at people that have less severe illness in the hospital. And there's other studies that are going to come looking at different antibodies in that patient population. In the outpatient population, so people come in, they're sick, but they're not sick enough to go to the hospital. Those people have been given a monoclonal antibody and studied to see what is the viral burden in their upper respiratory tract do, and what is the rate of hospitalization or ER visits that they need after the injection. So there's been two studies that have come out, one in New England Journal of Medicine, one as just a top line result from the manufacturer that's showing promise, especially in these secondary endpoints of decreased hospitalizations. And so that's where a big focus is, and those companies have applied for an emergency use authorization for the drug in that population. We'll see if that's granted by the FDA on the very limited data that they have. The challenge with them is that there's just not going to be that many doses of monoclonal antibodies to go around for the US or the world. And so, but it's one to watch because it definitely holds promise. And we've seen this be beneficial in other infectious diseases, particularly RSV and Ebola. And so that's, a good direction we're going. And it would also offer a therapeutic for patients in the outpatient that are not necessarily sick enough to be inpatient in terms of prevention of hospitalization, which is going to be key.
Does that become another situation of like priority of who actually gets those as well? Like, or is there going to be in the authorization some sort of, okay, these people would get this first, then this group, then this group? Is that the thinking with this as well?
There's going to have to be. And so in the discussions with the FDA so far, if these come to an EUA, this drug will be allocated to the state, just like remdesivir was. I mean, keep in mind, when remdesivir got an EUA, the state got an allocation, and then the state divvied up that allocation amongst the different hospitals based on volume. And so I suspect that'll be the same way that this would be done. It would be an allocation to the state. State would then allocate University of Utah, Intermountain, HCA, Steward, they all get your amount. And then there would be work on defining criteria for who would get these drugs. And, clearly what you want to do is you want to prevent hospitalization and death. And so you would prioritize these drugs to those that are at the highest risk of a bad outcome. And so you can imagine that you'd be prioritizing the older patient with underlying comorbidities, diabetes, hypertension, obesity, for example. Those would be the people that you would prioritize this drug to. But that will all have to be worked out on a state collaborative basis.
Last question for you, and it's kind of the magic 8-ball question. How can the state of Utah, and I mean, even the country, overcome the spike that we are currently in? And what precautions can we continue to take to help alleviate what's happening?
Yeah. So I'm going to just be kind of bold and say, like, what I would think if I were in that position to kind of make those changes. We've been pleading with communities to wear masks. We've been pleading with communities to practice social distancing. We've been pleading with communities to not gather. And yet our case rates are the highest they've ever been. And so us continuing that same message is great, but at the same time, I'm not expecting anything to change. All right. Like, we've been doing this, and yet we haven't had anything to change. So if it were up to me, and this is just based on science and the data that we've generated both here in the US and abroad, is that we need a break. We need some type of interval where we stay at home. We don't have social gatherings. This wouldn't be a shutdown, right? You can still have essential services, open. You could still get takeout from restaurants, but you're not going to go to bars. You're not going to go indoor dining. There's not going to be school activities. There's not going to be sporting events. You can still go to school, but it's masked, but there's no events. We need some kind of aggressive and bold public health intervention now to really break this cycle of community transmission. And what that would do if people stayed home and they didn't have 1,000-person people parties for Halloween is that you would see a dramatic reduction in community transmission. It wouldn't go to zero, but it would be dramatically reduced. Subsequently, our hospital volumes would be reduced, and then you'd monitor it very, very closely. And maybe you have to repeat that 2 to 3 week interval break every so often to continue to drive that community transmission down. But something has to change. Us just saying wear a mask, I'll be great, is not going to change this. We also don't have millions of, new tests to incorporate right now to drive, change. We don't have a new therapeutic that we're going to be able to intervene this week. And so, what we need is a temporary pause, and we need to stay home, and we need to shut some things down temporarily, and then allow us to have a lower community transmission, which then would allow the economy to be, a little more successful, especially as we go into the holiday season. That would be my role. And, that's been shown to be effective in Europe and multiple other countries. It's not a novel thought, but that's what we need.
Yeah, I happen to live in the UK, and I know that they just went back into lockdown about a week ago. And it'll be interesting to see what happens the next couple of weeks, especially leading up to Thanksgiving, because if that happens, when does that happen? Or if you take that initiative upon yourself, when do you do that? So it'll be very interesting. Eddie, as always, thank you for joining us. I appreciate the insight, and we will chat with you next week.
Thanks, Amanda.
Thanks.